everybody. It's so fun to be back in Santa Barbara. I really miss it here, and it's nice to see some familiar faces. By the way, this is Maisie. This is my girl Maisie. I'll just put her down. Yeah, it's a good girl. Oh. She's like a prop, because then it doesn't matter what I say now. That'll be fine. Okay, guys, so this talk, I use this title, Not Whether But How, because the TED guys changed the title of the talk. They called it What Matters Most at the End of Life, which is fine, but I wish I put a question mark on the end of that. I don't tell anybody what matters at the end of life. Of course, our patients tell us that. But I do like this title, Not Whether But How, because I remember, not so much here, but we're at UCSF and where I was in my fellowship, you almost had the feeling that we had to argue whether death was real, whether death existed. So you found yourselves in these inane conversations with extremely bright people that seem to question this very idea that death is just a part of the deal. It just is, and it happens to 100% of us. So I like to so not whether we die, but I think the more important question for most of us is how we die, or where we die, or when we die, all the qualifiers. So that's the nature of the title. There's a subtext to it as well, which is for my field of palliative care, which I will talk a little bit about that, but I know you guys know it well. There's such a good program here at Cottage. But the field has really ascended. It used to be a question of whether the field was going to make it to the main stage, and it kind of has. So not whether palliative care is going to have an influence on the healthcare system, but how are we going to do it? So bear with me. I must say the talk here is really, I must say some just painfully obvious things, some things that you guys already know. And the slides are really just prompts. And hopefully we'll have some time for questions and dialogue, but it's just to try to get us in a different mindset together. But I'm going to start with defining palliative care, because even if you guys were all palliative care clinicians, I still would start here, because I think our field is so hard to define and we misrepresent it all the time. All right, so I'm just going to shut up and let us read it for a sec. All right. So this is from CMS, not the most poetic guys in the world, but this is a hell of a definition. If you think about, contrast this with the rest of the fields in healthcare. From a medical point of view, and I should excuse me, I know I'm at a nursing symposium, but my training is as a physician, and I'll keep falling back into some doctorly stuff or medical-centric stuff. Bear with me. But think about a cardiology or nephrology, defined by an organ or a body part or tissue, But here we have a field defined around suffering. That is a real stunner. For one thing, who here hasn't suffered? Anybody? Any poor sap in here not suffered? And I say poor sap because I'd feel really sorry for if you hadn't, because you think about all we learn from suffering. I'd be the most boring, dull person on the planet were it not for the suffering I've had. But it is a universal thing, right? 100% of us have suffered. Actually, one person, I've asked that question, one person raised their hand that they hadn't suffered. And this poor guy, he came up after the talk, and he was all curled over on himself, and he's like, I'm so sorry, I screwed up your spiel, and my parents bought me a house and they gave me everything, and my life's so easy, and he was so anguished. And I said, sir, you're suffering right now in front of my eyes, so it was hilarious. So I will still say that 1,000% of us suffer. And the reason that's amazing as an organizing force for field is that means that we all have something to offer this picture. This is not something that we go study and learn and attack a knowledge base around. It's something that we get to bring ourselves to the picture, and truly, and actually really mean that. And that means that the bedrock for this approach to care, therefore, is empathy. And I think about my poor friends who are neurosurgeons, for example, and their whole life revolves around this organ and these series of procedures, but they've never had them themselves. And there's an unbridgeable gap there for them, even though they work on it all the time. How many brain surgeons have had brain surgery? How many palliative care clinicians? How many nurses? How many, have suffered? All of us. Okay, so this allows us to bring empathy into the mix in a real way. It requires it. So that's amazing. Another thing amazing about this definition is suffering is, no matter, okay, we've all done it, but I would still say it's hard to define. It's entirely subjective. I can't put a probe in my patient to say whether they're suffering. Our patients tell us. They demonstrate whether they're suffering. They own this. So this is so beautiful because it upends the power dynamic in healthcare. That, as we all know, even no matter how kind or nice we may approach our patients, there often is this vertical orientation and fear around it. And I understand that. I've been the patient, and looking up at all these white coats and who know more about my body than I do, et cetera. But on this note, the patients know just as much, if not more, than we do, and that's real. The other interesting thing about this definition, first of all, is that you see there's no mention of death. So, of course, again, bear with me, you guys know this, but the biggest thing to get across to each other and to the public is that palliative care, you don't need to be dying to get palliative care. Right? Hospice is a subset of palliative care that comes at the end, but there's no mention of time here. If my patients at UCSF and the Cancer Center, I've been seeing some of them for 10 years. Some of people are in remission, are not even sick anymore, but they may be suffering. So the thing we have to really get in our bones is that you don't have to be dying to receive palliative care. Too many people are suffering with something that would help them just down the hall, but they don't feel like they're qualified for it yet. Okay, thanks for the public service patience with me. Okay, suffering. So what is suffering? Real quick. I think of it as a wedge, as a gap in myself. So for me, there's the world you want and there's the world you have, and when those two things don't line up, that to me is the wedge of suffering. That's where and it gives us our two choices as a response as human beings. We can change the world. Not so easy, but we still try, and I think there's some real power to that. Or we could take the more sort of Buddhist or contemplative approach and quit trying to change it, quit desiring the world to be something other than it is. It's the other way to not suffer. So for me, in my own experience, and think about for yourselves, but for me it was about 5 years after my accident in college, when I got these injuries. It was about 5 years until I stopped comparing and contrasting my life now with what it used to be, my new body with my old body. And at some point in there, my worldview accommodated my illness. I no longer looked in the mirror and saw what I was missing. I just saw what I had. And that's when I stopped suffering in this way. I could still have pain, but my worldview, my sense of self accommodated my illness. I know you guys know this, right? Especially with our language around war on cancer, for example. It's powerful. It mobilizes activity and energy in us to kind of go to work and push back on this force that's taking so much. And then we also are aware of the fallout of that approach too, because ultimately we're at war with ourselves on that one. And it's one thing when our cancer is curable, and you can really vanquish that enemy. But what happens when you're not curable? This is where we as a system get into so much trouble. Our language doesn't suit. We make people feel like losers for not surviving. And of course, I don't mean that personally. I doubt anyone in this room is doing that in any way intentionally. I just know, speaking from the medical side, our language certainly sends that signal. They failed chemotherapy. No, chemo failed them, if anything. Okay, I'm ranting, sorry. But I will say one thing, so whatever suffering is, no one of us has a lock on it. No one discipline has a lock on it. That's why this work is inherently interdisciplinary, and that's another thing I love about it. Okay, so there's all these different ways to suffer. I will just throw in there something that I've already implied, which is this thing that I'm calling logistical suffering. Because if we're honest, this healthcare system, which does help us deliver a lot of good to a lot of people, and to have work that we all find meaningful and important, but if we're honest, I think we have to kind of say, too, that there are times where this healthcare system actually causes suffering, is the source of the pain. And that sucks for a number of reasons, especially as I think for myself with burnout. I don't burn out because cancer exists, personally. I mean, I don't love that cancer exists, but that's not what tears me apart. That's Mother Nature. That's something bigger than me. What tears me apart is the sort of systems issues that get in the way of my job or of patients receiving the care that they want and need, et cetera. Those are the things that drive me bonkers. But the good news on that front, and the reason to call that out is, well, the healthcare system, we invented it. It's not like the heavens opened up and plopped this system down on us. It's a made-up thing, so therefore we can change it. And I just want to kind of keep calling that out. As demoralizing as that can be and as difficult it is to change, it is possible. It's an invention, after all. Okay, so the rest of these slides, again, are just going to be kind of prompts, just food for thought, really. And again, trying to get us into a different mind frame. So one question I think that is so valuable that doesn't get asked enough clinically or otherwise for us in the field too, of why are we doing this again? Why are we getting out of bed? Why am I working so darn hard? It's a question I think we should ask ourselves a lot more often. But I also think of it therapeutically, we should be asking, well, why am I doing this treatment? Why am I suggesting this or that intervention? I think too often we do things because we can. We don't stop and ask the question of whether it actually serves us or serves our patient. So I'm just suggesting plopping this question of why into our mix on a daily basis, getting really familiar with asking ourselves that and each other that question, not in a confrontational way, but in a therapeutic way. It'd be very, very helpful. So, okay. So if we ended up with this healthcare system, we all know, right? We all know this healthcare system of ours is packed with people who really mean well. I mean, think about the work you guys do, all the training to get to where you are now, the hours and hours spent, the sacrifices. I mean, it's remarkable. Medicine, nursing, social work, chaplaincy, volunteers, the administrative load, et cetera, et cetera. I mean, this system is filled with people who really, really care and work really, really hard. And yet, we have these failings, we have these problems. So how do we reconcile that? So the way I would see it, and maybe you guys, I wonder what you think, but I just think of it, there must be a design flaw. If a system that means so well is doing so poorly sometimes, there must be a problem in the design of it. And I think that's good news for us because it also lets us, we're a little bit innocent. It's not, I feel this as a physician. A lot of my patients, I don't know when the days were when doctors were God. But I haven't experienced that. I meet a lot of my patients who, it takes me a long time to get their trust. They're coming with great suspicion when they first meet me. I feel that a lot. So anyway, I think we have a design flaw. And for my money, I think what it is, we've decided 150 or 170 years ago or so, let me go back to this slide, that we were going to focus on diseases. Okay, and then it seemed, that's not nefarious. It seemed intelligent enough. And then you start having interesting things happen. Penicillin comes along. Infectious disease was the number one killer of people, and all of a sudden it looks like I have a cure for this. Why I would be celebrating the end of infectious disease. I think I would have gotten caught up in that too. And would I have ever thought that these bacteria are going to be smarter than me and my drugs and be able to get resistant to my drugs and circle back and beat me harder the next time? No, I would never have guessed that. So my sense is that we're in the midst of a reckoning. that we have to kind of come to terms with how we're doing things and how it's working and how it's not working. So this gruesome picture is a painting called Ether Day, and it is depicting this moment at the Massachusetts General Hospital in 1846, the first time that ether was used to put someone to sleep, to perform a procedure under anesthesia. Those of us who have surgery are very happy for this invention, thank the gods for ether and anesthesia. But this is a moment where, one, science and medicine got together. Medicine wasn't always the stuff of science. That's a relatively new phenomenon. It was much more a mystical activity. Now science rules, technology's ruling, innovation's ruling, objectification's ruling, and you can see it right here, right? This is a moment where you can separate the person from the body, put them to sleep and do all sorts of things to their body. Great when you need it, but again, there's fallout to that. We don't really recombobulate the person that we've just pulled apart. And again, it's put us on this mission, this seduction that we're going to stamp out all diseases and everyone's going to live happily ever after. All right, so 170 years of that way of thinking, a lot of good has come from it. Now I think we're at a reckoning where we have to kind of pick up the pieces. Okay. Oh, well, I didn't really finish the end of this. So, disease-centered? Okay, yeah. You've been a patient, you probably know what it feels like. You kind of feel incidental to your disease. Like, I'm the vector for my disease. That the physician or the hospital kind of tolerates my presence while they're playing with my disease, I don't mean to make too much of it, but that's not too off. Okay, so person-centered. Well, that sounds enlightened. Great. Okay, but then, and if we could get there, that would be awesome. But I stop and think about that, and we have this problem in medical ethics around autonomy. The thing is, no one's autonomous. No one's in a vacuum. So if you just focus on the person, I think you're going to miss some things there too. Where I think what feels most enlightened to me would be this idea of a relationship-centric approach to care, because that brings us into the mix as the clinician, as the healer, as well as the patient. And we all know that that's where the juice is, in that therapeutic relationship. That's where so much good is coming, for us as providers as well as for the patients. And ultimately, I hope you can probably feel this. The giving and receiving care are deeply entwined. It's a two-way street, and when it works best, it's going in all directions. So maybe the idea is to really focus on a relationship. Okay, so here we go with our prompts. Okay, the power of impossibility. I have felt this in my own life. What a relief impossible can be sometimes. So living in the Bay Area is wonderful and drives me crazy too, because nothing is impossible. We're going to disrupt and we're going to innovate and everything's going to be better and we're going to stamp out this or that. And okay, I'm into it, cool. But at some point it's just, again, we run the risk of implying failure when it's just nature at work. There is a real therapeutic potency to something being truly impossible and calling it out as impossible. My example just as I think about this in daily life, I'd love to go to Pluto. I think it would be so cool to walk on Pluto. Do I waste much of my time angsting about not going to Pluto? No, because it's not possible. All right? And so let the impossible stay impossible sometimes. We doctors do this a lot. We're conveying a hard diagnosis. You can feel the freedom being ripped from the person, and you're spastically looking for a way to give them some sense of choice, because choice implies freedom, implies agency, etc. So we doctors oftentimes end up offering choices that are not real. And for my money, this is our new negligence. I really believe that. Not only do we then just accidentally and unwittingly chew through this person's time, propping up this charade, but we've robbed them of the innocence of something being outside of their control. We've set them up to feel like they're failing. So as a system and as a people, I think we need to come to terms with and even embrace impossibility when that's just actually the truth of it. Okay, quality of life. Okay, health. If you have your health, you have everything. That's what they say. I don't know. I know about you guys. I know a lot of guys with perfect cholesterol, great blood pressure, they don't meet criteria for depression, and they're, walking zombies, there's no, I don't think health is the absence, or I don't think well-being is the absence of disease. So I'm interested in having my health, whatever the heck that means, so that I can do things with it, so I can enjoy my life, so I can be of service. So for me, sometimes I hear our language around quality of life or well-being, and it comes off as this limp kind of second-place finish. "Oh, I'm so sorry, Mrs. Jones, we can't cure your disease, but we can go for quality of life." And it's like, I think it's like, I think we can, another thing we can invert. So if we're just rethinking all this, wouldn't you say that quality of life, well-being, is even the bigger goal than is health, right? That also gets to the subjective sense of things. So I know a lot of people who do not qualify as healthy, but who do really qualify as well and whole, all right? So I think, and part of our healthcare system is so gargantuan, if there's something, if we could be working on behalf of something even bigger than our own self-interest as a system, like health as a piece of society being well and being whole, wouldn't that be great? We'd be in service of something even bigger than this system. This just kind of gets at the same thing. A lot of patients come to us because something's gone wrong. That's just the truth of it, and that's okay. And if we can actually make their life less hard, less shitty, sometimes, that's really great. I'm not asking for us to be even more ambitious here, but I do think we should keep an eye out for where life could actually be even more wonderful, so that amazement and awe are also in this picture. There's a lot of therapy in that, and also for us to work within it. And I'm not saying it's not big stuff. It's bedside manner usually gets kind of relegated. It's a nicety, but I would say it's more essential, towards this big end. Someone makes my day by just a little, a thanks, or holds the door open for me, or just a little eye contact at the right time, or a wave if they just cut me off on the road, or whatever. Just something really basic. It's not fancy. We know this in our own being. I'm just saying that we should rope that stuff into the mix. It's not okay to be a jerk, really ever. We tolerate it because they're a great technician or something. And we can do better. Okay, you guys, do we know who this is? Yeah, sorry. I know this is a stacked audience for this question. Sorry. Yep, that's Flo, Florence Nightingale. Yeah. So if you read this book, Notes on Nursing, still in print. So she was around at the same time, a little later in the 19th century than the ether moment. But she's also around where medicine and science are in bed. And if you read this book now, you will see that what she talks about a lot were aesthetic things, the world of the senses, flowers, fresh cut flowers, light. She even talks about the floor wax that she likes to use because of the certain feel, the sheen, because she knows she's part of cultivating and fostering an environment where certain wonderful things can happen. And for me, this is one of my favorite this word, aesthetics. I love this word. As a patient, what I came to appreciate was that I had a body at all that could feel anything. And I got really, really keen on loving that I had anything of a body left so that I could still feel stuff. That's why I liked having this thing. And I could see things, I could smell things, I could hear things. So there's something really primal about this whole world of the senses. And aesthetics has come to mean pretty, but it's not just pretty, it's sensory. You can think of it by its antonym, which is rampant in medicine, which of course is anesthesia, where numbness is the goal. And frankly, my time as a patient, being numb would be fine sometimes. But I think this higher end of protecting the world of the senses, of feeling our way, is another way of honoring the body. There's a historical thread for it that Florence points us to. But I also think of this as because the world of the senses is a direct experience. You don't have to think about it. You can bypass your frontal lobes. There's no intellect required to feel something. And for those of us living with dementia and caring for folks with increasing levels of dementia and intellectual decline, but they're still alive, my money's on the aesthetic domain to continue to have some life until they really are gone. The aesthetic world is not it's not strategic. It's not on behalf of something. So if you look at a mountain, a beautiful mountain, these mountains behind us, it's one thing to have an aesthetic moment, is just appreciate that they exist at all. And you're just connected to them, you're in appreciation. And it's immediate. You don't need any time to experience that. And there's no strategy involved to consume your intellect. A real estate developer looks at that, says, oh, condos here, mall there, whatever else. That's no longer an aesthetic appreciation of that mountain. All right? It's different. It's okay. But it's different. The thing I love about this is it's immediate, no time required, no intellect required. I think it's where we should keep our bottom line for our patients, especially for folks who are no longer able to think so clearly. That doesn't mean they're of no value, of course. All right, so the fun of these slides, of course, you just get to say whatever you want. And so for me, like one of them, like if I were, there's a little bit of a critique of the healthcare system implied here, obviously, and there's a little bit of a critique of us as a society, too, just to call it out. So one of the things I wish I'd been taught early was the difference between discerning and judging. So those two things were one and the same for me until I kind of really had cause to think about it. We humans are really good at discerning, noticing symmetries and asymmetries and color and tone and texture. We notice contrast very, very well. It's how we navigate the planet. And it's impressive. But we do this extra thing where you notice differences and then you heap these judgments on them. And I wish my teachers had just told me the difference, and so I could catch myself before I went to judgment. I'm just noticing difference. Not better, not worse, just leave the adjectives out of it. I'm just noticing difference by way of, I'm seeing you, I'm honoring, just by being seen is an honorific. I want to be seen, I want to see. But I don't want to be judged. That's different, and especially for us in healthcare, I think it's really important that we watch ourselves on this one. Okay, meaning making, great. I'm all for meaning. Meaning's cool. I love it. We humans are really good at making meaning. Well, I should say, I'd ask you, depending on your belief system, you might think that meaning exists, and our work is to find it, go uncover it. Or you might think that maybe there's no such thing as grand meaning, but we can make it. We can make meaning. Either way, meaning flows through human beings, and we can inject meaning into just about anything. And it is a powerful, powerful force. I am all for it, as is purpose. But what about life when you can't find meaning and can't find purpose? I've struggled along those lines myself. Maybe you guys have too. But I kind of came to realize that didn't mean that there was no value. If I couldn't find meaning and I didn't feel a sense of purpose, it didn't mean that my life was over. Again, I could still feel things. I could still revel in existence at all. So I would love us as clinicians to keep an eye out for, because patients, you know this, patients are making meaning from everything we do and say all the time. We are just these loaded projection screens that people are going to ascribe meaning to, whether we smiled at them or didn't, whether how we phrased the news we're delivering to them. Anything, it's just everything's so loaded. And we could say that's not our job to make meaning. But you would do yourself and your patients a disservice, because you are going to be involved in their meaning making no matter what you do. So I think we should kind of cop to that and come to terms with it and work with it. And I also want to call out, and one thing that death has done for me has made meaninglessness okay, even delightful and strangely stunning. Okay, so words, words, we give words so much power. And okay, I'm fine with that. They deserve it, I suppose. They're very useful. But it's, especially when it comes to advanced directives and stating wishes, et cetera, like if you can't say it, can't write it, it's like it doesn't exist. I guess I just want to call attention to the world. The means of communication have nothing to do with our words. So much communication is happening non-verbally. And I just want to make space for that and delight in that. And also it's also, as we have a population more and more subject to dementia, I think of this with feeding tubes. Because someone is nonverbal and can't tell me they don't want a feeding tube, but are pulling it out every time I put it in, I would like that to constitute communication, right? So I'm talking on a few different levels on this one. Okay, acute and chronic. Well, we're really good as a system in acute care. Trauma centers, ERs, hospitals, we're really, really good at that. I'm not suggesting we somehow get less good at that. But what we're not so good at, and you guys know this, is taking care of people over time. Chronos, chronic, it's in the name. We don't, as a system, because that system was all hell-bent on curing the disease, right? So there wouldn't be a need for chronic care if we were more successful. Chronic illness, for clinicians, in a way, is demoralizing because it implies that we couldn't fix them. But that is just the nature of the beast. That's the nature of life, and we're all going to be dying from chronic illness. That's the way we're going. So we as a system, we have to kind of come to terms with that. We have to build infrastructure for it. We have to have different training, because think about the training that goes into taking care of someone over time. Well, sorry. Acute care, you're intervening in Mother Nature. The patient really is trying, you just like, please hold still, patient, I'm going to do stuff to you. There's no time to talk about it. Okay. That's one muscle. Chronic care, that's very different. Things slow down, the patient has the power, and the power comes largely from their ability to adapt. And one of the things that's so amazing about limitations when we humans come across them is they're not so bad, these impossible things, because we come up with these fascinating workarounds. Anyone, if you guys know, who have dealt with disability or any limitations in your life, that's someone's creativity in us. That's where we really actually shine. That's not where we should be warehoused and gotten out of sight, like the old model. There's no shame in it. There's a lot of pride in it. So we have to get better at acknowledging that in our patients, unleashing that, fostering that. But more to the point, in chronic care, our role really is to support people and sidle up next to them, not lord over them with power and understanding that they can't have. So it's a very different muscle, a very different energy. Excuse me. Okay, another way of putting this, curing, great when you can do it. The problem is when you can't do it, then we run into trouble. And so maybe a bigger goal, I learned this from Rachel Redmond, excuse me, is healing. So healing seems always possible. And it's much more up to the patient than is curing or fixing. So you guys, I'm sure, have known many people who have died, whose bodies have completely, utterly come apart, but as a person, they are intact, they are whole, they are healed. So you can be dying and be healed. You can be dismembered and be whole. You can, it's a bigger, better goal. All right. This is a nod. Excuse me. This is a nod to mystery. Something I kind of highlighted earlier, but we need to make more room for not knowing in healthcare. Again, when we're beyond curing, there are things at work that we just don't understand. And if we were all the smartest people in the world, we would still know that there's a lot we don't know. And that's not a failing. That's not a shame. In medicine, that starts smelling like ignorance, and that starts smelling like, no, you got to go back to the library. You got to work harder. But no. Yeah, yes, I'm all for knowing things. We've got a weird relationship to knowledge right now, right? We're pretending to not know things that are facts, and we're calling facts things that we don't know. It's very strange. So I think we got work to do on both sides. Let's know what's knowable. Oh, thanks. Nurses, yes. Hi, baby girl. So what was I saying? We have to know what's knowable and be honest about that. And it's not a plug for laziness, but also being in touch with all that we don't know. Looking up in the night sky, we're all on the same planet at the same time, in the same galaxy, in the same universe, and there are like 800 million zillion of them. I just can't, it just boggles my mind, and it's beautiful, and I feel like most of my troubles can be answered by looking up in the night sky. And part of that is just being a teeny little part of something that I don't totally understand, but I'm part of it. I think there's beauty in that, and most of my patients do too. Good girl. Okay. So, this trick, sometimes we say the poor, the homeless. It's a rhetorical trick. You put the in front of it, and you may really care about that population, but you're saying, I'm not part of it. So we talk about the dying. You're saying, I care about the dying, but I'm not those guys. This one, guys, we all are. And there is a difference. My patients who are hours away from their own death, they know things. They're in a position that I can't totally understand. It's not okay for me to say, hey, you're dying too? Oh, I'm dying. That's not, I don't mean to overstate that. But I'm just saying that we should not unnecessarily or unnaturally separate ourselves from each other when the facts imply or point otherwise. So we are the dying, guys. This one should be 100% of us get sick, 100% of us die. It's not a failing. It's normal. I'm normal for having, amputations aren't normal, but I'm normal for having something go wrong with my body. If it weren't that, it was going to be something else. All right, so one of the things we say, and the disability community knows this very well, there's a lot of tension with healthcare, in part because we imply that disability is a failing, that because they have pathological cells, that they're pathological. So it's subtle sometimes and blatant sometimes, but it's a real problem, and we should watch ourselves around this. Okay, myth of independence. This was probably my favorite lesson out of my own disability, came the realization that this was another kind of, I wish my teachers had told me this when they introduced the word independence, that, it doesn't really exist. I wish they had said independence is not possible, but it's really cool. I would like, it's on a spectrum. You can be relatively independent, and I fought very hard to regain some modicum of independence. But we are all on the spectrum of interdependent. Okay? I do not think, you tell me, I don't think a person, an independent person has ever lived or will ever live. And like the suffering guy, who wants to need no one? You're out of the club then at that point. And for my money, I think we should see ourselves on this spectrum. And another way, we don't need to separate ourselves from each other. We all need people. We all need each other. It's just the truth. You can be just somewhere along the spectrum. It's not like independent guys go over there. We've got this nice little nursing home over there for you dependent people. That's the way it looks, but it's just not real. Okay, this slide, nothing to note here except for these are data from the California Healthcare Foundation. We asked Californians what was important to them at the end of life. The point on this slide is how few of these things have anything to do with medicine or clinical care. So if we really want to be like helping people deal with end of life, we have to work much more broadly. We have to collaborate much more broadly. Healthcare doesn't have all these answers. Being a burden, you guys may have heard this phrase. It comes up, so now in California we have assisted dying, aid in dying, which you guys probably know. The newer language for what used to be called physician-assisted suicide. And one of the things that gets invoked in that conversation a lot is that people are actively who love their life, but actively want to hasten their death because they don't want to be a burden. And in that slide before, the word burden comes up twice. Okay, I get it. I have been a burden. It's no fun. It was painful. But when I talked to the people years later that I was ostensibly burdening all those years, they said, "You idiot! We weren't kind to you when you were in the hospital so that you owed us something. We learned so much from that time too. Thank you for letting us help you. It was, as I said earlier, the caregiving and receiving was going in all directions, and that's when it was really something. It was really working." So I had felt like a burden, but totally unnecessarily. I was suffering unnecessarily. So I think part of this is an indictment on us as a society. I think we kind of suggest that when you're peak productivity, you're really welcome here, But as you kind of, that aging was just a process of kind of getting out of the way, making room for the next wave of producers. That's a tough message. The truth of it is, like this interdependence, there are just asymmetries in a life. There are times where you're going to need to take more than you can give, and there's going to be times where you can give more than you can take. Just part of the deal. And I'm particularly pointing at you guys, and myself too. All of us in healthcare, we are, I don't know about you guys, when I see my new patient is a clinician, I go, oh God. In part because we caregivers oftentimes aren't so good at care receiving. It's a different muscle. You might say, oh, everyone wants to be loved. Well, I don't know. Not many of us are very good at it, actually. I'm actually pretty crappy at it. So it's a different muscle, and if you want to have a full life, you got to learn how to receive care too. That you can't have it just one way. You just have half a life. So this is a painting by Nicolas Poussin, 17th century. I love this painting just because, well, the title is Et in Arcadia Ego, which is Latin for I too exist in paradise. So these guys are wandering around paradise, and they're looking to come across a sarcophagus, a tomb. They look at each other quizzically, pointing at the inscription, and say, what is a tomb doing in paradise? And the ego. So it's not I was here. It's not like an inscription by a guy who died and was saying, I used to be alive and live in paradise. I am in paradise. The translation for me in this painting is a reminder that death may have something to do with how we experience paradise. I'm not saying we need to love death, but it does seem to be part of the deal. And if I think about the things that are precious to me, why are they precious? Because they end. So we humans are so relatively wired. If we want to enjoy things, you kind of have to know the longing for it. You kind of have to know pain to know pleasure. I just don't know that there's any way around it. And the good news is we're going to get all of that in spades, no matter who you are. There's going to be plenty of pain for us. But it's just a nod to realize that, and humbling to realize that I think death has a lot to do with appreciating life. And I think it's a charge for us as clinicians, but as people, I think the charge for us, the death lesson is that don't wait till you're dying to actually appreciate what you have. That's what I learned in the hospital. My whole hope for myself is that I can learn to appreciate what I have while I still have it. All right, guys, that is the end of the barking at you. But I don't know if there's much time for questions, but I'd love to hear any thoughts or questions you might have. Yes, ma'am.
Tell me about your dog.
What's that?
Tell me about your dog.
Oh, yeah. Well, so Maisie, she's not a service dog. I'll let you in on I pretend she is. I just walk around with her. I don't lie. So when people ask me, I don't lie. But I just walk around with her like she deserves to be there, and usually it works out fine. I used to have a true service dog back in the day when I got out of the hospital, and it was an amazing experience. But Maisie is a huge part of my life. When I was working at Zen Hospice Project, it was great to take her to the facility, to the hospice house. But in terms of like meaning of life, like she's another thing. Like I learn so much from a dog. I don't watch my dog wishing for a life that she doesn't have. She just gets busy in living the life that she does have. And I learned that really helped me when I was a patient. And also the sort of, when I think about what I love to do, what gets me through a day, it's not so much the purpose stuff, it's the purpose, like playing fetch with her. I'm not doing it to exercise her. I mean, that's nice. But there's a primal, just a joy in playing fetch with her. Similarly, there's like a joy for me, I love riding a bike. I don't do it for the health of it. If you told me that the new data suggests that riding a bike is worse than smoking, I would still do it. Because in the moment, it makes me feel connected and good in the moment, right now. And I get that a lot from Maisie. So that's Maisie. She's 7. She's half pit bull, half German shepherd. I know, I love saying that. But anyway, yes?
Hi. I'm in my early 50s, and I remember when I was a kid, people died of natural causes, especially people over 80 or, in their late 70s or so. What did they die from? They died from natural causes. Nobody dies from natural causes anymore.
Yeah. I don't even know what that is anymore, right? I mean,
But it's a good way to approach the DNR talk.
yes. Yes, and I think I like the language around DNR. You may have heard this at some. There's a movement to change that, to reframe that as allowed natural death, as a sort of a more positive and truthful orientation, and that is meaningful to me. Right, somehow we got seduced, and I did my internship in Milwaukee. My family was in Milwaukee, and it was so interesting to watch the folks coming in off the farms who were dying in the hospitals just because they couldn't get home for one reason or another. But those guys died differently. And I think it felt like because they were around nature in a daily way that we in the cities and suburbs, we lose touch with. There's nothing, we don't need to master new information to die well. We've been doing it a long, long time. We have to kind of recapture maybe some stuff that we lost. But nature, we're born to do this. We know how to do this in our bones somehow. It's just all these man-made things that have come, these barriers to a good death that we have to navigate, and that's where the expertise is. Otherwise, this is what we do.
I have a quick question.
Oh, yeah, hey.
Hi. I work at a small practice, and I have two amazing doctors that really love their patients, but I've noticed that sometimes it takes an extremely, extremely long time for people to go into hospice care. What can I do as an oncology nurse to broach that with my doctors? I don't know if it's them feeling like they've failed them in a way, or if it's just that patient, if they've actually had those conversations, and if those patients are just sticking it out to the bitter, bitter, bitter end.
Yeah. So it's a great point, and there's no easy answer, obviously. This is why I think anytime I like to pair any critique of the healthcare system with a critique of us as a society. I used to, when I was early on as a doctor, I remember I and a lot of my classmates, we were very clear that we were going to be a different kind. We were going to tell the truth to our patient. We were going to be very caring and very whatever, implying like these other doctors were just lying left and right to their patients, and which was, of course, not the case. It was a real lesson to me early on when I heard from a patient who said, well, my doctor never told me this, and I had no idea. And so I went storming over to that doctor and said, how dare you? And he's like, look at the chart, dummy. I had this conversation 18 times. I've talked to their family about it. They just don't hear it. They can't hear it. Now, sometimes that's because the way it's being put to them is not particularly supportive, and there's a way to convey this information that is kind and thoughtful and compassionate. There is a way to do this. But very often, there's a dance, a collusion, patients and clinicians avoiding this brutal reality. The doctors don't want it, it's demoralizing for them, they don't want to hurt upon someone's feelings, so they don't bring it up, the patient doesn't bring it up because they don't want to think about it, and around you go. So it's complex, and it's on all of us. My answer to your question is, I think you got to think of it on a few levels. One is to be part of a society that just treats reality as just as real, has a different relationship to the inevitable. That's kind of why some of my comments are poised at that sort of mega structure. That's a piece. I think we should all be honest and wear our suffering on our sleeve a little bit. Just be obvious that this is just part of the deal, so we don't seduce people into thinking they're failing for suffering or failing for dying. So we should share differently as clinicians, I think. I think tactically, if there's some real, the diplomacy of nursing is intense, and you guys know better than I, but pulling a doctor aside, not in front of the patient or their family, either after, preferably even before a meeting where you're going to a family conversation, you can broach it. Is hospice appropriate now? And they say, no. Say, well, gosh, why not? I'm kind of thinking maybe it would be a good idea, X, Y, or Z. See, that way, if you can in a non-threatening way open up a conversation before that family meeting where decisions get made, that can be really, really powerful. And then following up, when a conversation doesn't go well, or when hospice is brought in way too late, if you have some structure for kind of reflecting on cases, this is where I think it's on all of us as humans to be courageous and say, this person should have had hospice sooner. Just call it out. Not like you jerk for not doing it, just as an honest critique of the situation. So those are some thoughts. The other thought would be, of course, this is where it's so nice to have palliative care in the building as a kind of a bridge and as a mentality. Even if palliative care team's not involved, just having it in the air can open up the subject nicely. So those are some thoughts, but it ain't easy. No. There's a lot to say about that. So do you guys hear the question, why there's some doctors that were, in terms of implementing the aid in dying, that you're seeing doctors are actively sort of, it seems like obstructing that process for patients or making them feel bad or seeking it. This is where, again, I think part of, for me, why comments like this, there's no data in my talk. How do you make any of this actionable? Yeah, okay, I get it. But we have to kind of have a different ethos. And part of that ethos is we clinicians have to see ourselves as human beings. And part of seeing ourselves as human beings is seeing ourselves as we don't have total control, we die, we suffer, et cetera. So this is where our personal reflection, I think, is really important. And my guess is those doctors either have not dared to reflect on their own mortality, or maybe coming from a very particularly pointed moral, religious point of view. But even so, projection is the enemy here. We should not be projecting on our patients our belief system. That is unethical. So what you're describing is probably unethical. We're in the early days of this law, and I think there's some resistance to the law because, in my field, palliative care is uniformly sort of neutral to against it because some of us feel like, where's the outrage that we're not helping each other live better until we die? We take all this outrage and just say, okay, so you're not so happy? Sure, you can get off the planet. Where's the outrage that palliative care isn't more accessible, that we're not doing more around quality of life, et cetera? So part of my field has this resentment that we're diffusing the anger that should really be applied to making things better for each other than just helping you get off the planet. So and then some doctors will invoke this idea, well, I took an oath, the Hippocratic Oath, and that I am a defender of life. That means keeping death at bay as long as humanly possible. That's just not my purview. So it's like conscientious objection. You can conscientiously object to this law. Absolutely you can. But that's when you say, I'm so sorry, Mrs. Jones, this goes against my grain, but I'm going to help you find another doctor who would be better suited to talk to you about this. That's the way it's supposed to work. None of us has to. You can always opt out of this if you have a moral objection. But so you're pointing to us being in the very early days of this. And so much like advanced care planning, doctors aren't taught or trained to have this conversation. Doctors are now at the gatekeeper whether someone can actively choose to live or die. I don't know that doctors deserve that responsibility, but it's sort of like I don't know who else to do it. So that's just a roundabout way of not answering your question. But it's complicated. It's complicated. I think that, but I keep pointing us back to we have to all get much better at reflecting on ourselves as flawed, dying human beings and then go from there. Yeah, I know it's unsatisfying, isn't it? Okay, guys, anything else? Wow. Very nice to see you. Thank you so much for having me back. Appreciate it.